I'm a clinician in Salt Lake City, Utah. I practice at the University of Utah and at the Veterans Affairs Medical Center, and I have the pleasure of taking care of our patients in those communities. I think one of the hardest things for folks that have come back to the Scleroderma Foundation meeting is to think of new topics or things that are important for you. And so I do encourage you, if there's topics that you'd like to hear about, make sure you write them down and let us know, because we're always happy to bring the information that's most valuable to you, to the community back. One of the suggestions I had was talking about emergencies in scleroderma. And I think this is really important because oftentimes when you have scleroderma, you don't feel good all the time. And so it becomes really difficult to know when to call your doctor or when to seek medical advice. And I think the key with any start of a talk is defining what we're talking about. And so a healthcare emergency is considered the sudden onset of a medical condition that has acute symptoms of sufficient severity so that the absence of medical attention could reasonably expected to put your life in jeopardy. And again, that's really difficult because the key words there are sudden onset, and many times our symptoms are very chronic. And then also understanding the severity. And scleroderma patients put up with a lot of pain, and so a change in severity may be more difficult to understand. So when we think through the kind of classic symptoms of a medical emergency, these are often the ones that if you call a medical provider, they will direct you to the emergency department. And that includes difficulty breathing, and we'll talk about why that can be difficult in systemic sclerosis to understand if that's a medical emergency. Severe stomach pain, also difficult in systemic sclerosis. Seizures or convulsions. Confusion, chest pain that causes sudden tightness in the chest. This is really difficult for a lot of patients. Refractory vomiting, but in the case this causes dehydration. One of the most common symptoms of dehydration is dry mouth, but that's also a symptom commonly seen in scleroderma, so difficult to understand when dehydration is present. Stiffness of the neck and sensitivity to light, which can indicate meningitis. A broken bone or a laceration or wound. We'll talk about wounds a little. And so why is that difficult to know when it needs to seek medical advice? Because oftentimes you have dealt with your own wounds and you know how to manage it pretty well at home. And then the two last ones are pretty common, and I think that most of us would agree. If you had a baby with a fever, or if you had sudden delirium, those would be medical symptoms that would go to the emergency department. But for all the other ones, we can talk about how it's important to monitor your symptoms and know how to prevent them so that we can properly seek emergency care when we need it. So specific to this talk, I would like to cover scleroderma renal crisis, digital ischemia, which is a heart attack of the finger, so where the finger is not getting blood flow, severe unremitting abdominal pain, and infection that occurs on immunosuppression. Additionally, we'll talk about when there's a change in respiratory status or chest pain that warrants seeking medical care in an emergency department or acute care center. So I'm sorry, I don't like to put a ton of information on a slide, but I know that they do handouts, and I want you to not to take a lot of notes. So please forgive me, some of the slides are a little bit wordy. But scleroderma renal crisis is one of the medical emergencies in scleroderma that all scleroderma patients should understand. The tricky thing with this medical condition is that most of the time, kidney dysfunction is pretty benign. So that means you get your labs back from your doctor, and you're generally looking for two values on your lab sheet. You're looking at a creatinine, and that may be a little bit elevated, or an estimated glomerular filtration rate. It's a little e and then a big GFR. So those two labs come back to your doctor, and it may be mildly elevated. And your doctor may respond and say, let's hold that any anti-inflammatories you're taking, because that can commonly increase that creatinine value, and let's recheck that value. And in the interim, let's have you keep an eye on your blood pressure. And so those would usually be the first step. Now, many patients in the audience may say, oh, that's happened to me before. my creatinine runs a little bit elevated, or my estimated GFR is a little bit lower than my doctor would like. But fortunately, we've followed these values over many times, and it's stable. And so that would be considered that benign course. Unfortunately, though, scleroderma renal crisis affects up to 15% of our patients. And so it is something that even if you are stable and you've had this benign creatinine course over time, you should still check your blood pressure and know where it runs. And the reason is we think just by educating our patient community that that's led to this decreased incidence of sclerodermal renal crisis since 2015. So just the community at large, talking and sharing information and training the community to check their blood pressure and know when it's elevated, that's something to worry about, has really helped decrease that incidence probably. Now, you're all sitting in the audience and said, you know, it's not very much fun to check your blood pressure and keep it a regular log. Are there certain clues in my medical history that could maybe make my doctor more worried about the risk of renal crisis or think about it with a little more attention? And all of you probably know what your scleroderma-specific autoantibody is. And if you don't worry. It's an easy question you can ask back to your doctor. But there's certain scleroderma-specific autoantibodies that help make the diagnosis of scleroderma. And oftentimes, those are the labs that led you to be referred to a rheumatologist. There is one particular one called an anti-RNA polymerase III autoantibody that's associated with renal crisis. And so if that is your specific autoantibody, it is worth making sure you have your home blood pressure cuff and that you're checking your log. And even if your rheumatologist doesn't ask you where your home log runs, that you know that where it's running. The other thing on physical exam, diffuse cutaneous skin involvement is associated with renal crisis. That means upper arms, thighs, and abdomen involvement. So if you're systemic sclerosis, the skin changes have passed the elbows or the knees, involve the abdomen, your doctor should think through your risk for renal crisis and make sure that you're checking your blood pressure. And then other physical exam features, such as tendon friction rubs, and this is when your doctor feels your joints, and oftentimes patients will say, oh, I know how to make that. It's that crunch that sounds like someone's stomping on the snow. You sometimes can say, oh, wait, if you move my wrist a little to the right or left, you can get it to move. That's called a tendon friction rub, and that's been associated with renal crisis. Additionally, inflammatory arthritis. And this is really tricky because the term arthritis means joint inflammation, but we also call it osteoarthritis, and that's wear and tear arthritis. So this is not the osteoarthritis or wear and tear arthritis. This is inflammation that's caused erosions or changes on X-ray or on joint ultrasound, and oftentimes is treated in the general rheumatology population with glucocorticoids. So that's prednisone or Solumedrol. So this gets really tricky. It's a little bit of a chicken and egg in that if someone comes to clinic with a lot of inflammation, the rheumatologist may prescribe prednisone or Solumedrol, and that is clearly associated at these high doses with renal crisis. And so it's maybe unclear whether it's so much the inflammatory arthritis that's associated with the scleroderma renal crisis or the treatment that was given for that. But if you are on prednisone or Solumedrol, it is absolutely mandatory that you're keeping an eye on your blood pressure, and that means tracking it on a home cuff and keeping a log measurement, because that association is well documented. The good news is that we can manage renal crisis fairly well if we detect it early. And so that's really why you are empowered by knowing how to check your blood pressure and if it's increasing, because then you know that you can get a treatment from your doctor to modify your course. And that's called an ACE inhibitor. This is also a little tricky because you would think, okay, well, if I have essential hypertension, which is hypertension that comes with age. If I have that, why don't I just start an ACE inhibitor? Because that would make sense. And then I should never get a renal crisis. I'm sort of treating it. And that's why this is a controversial area, is there's some thought that if you just use an ACE inhibitor, and those are your drugs that end in pril, so lisinopril or captopril, if I'm just taking that medication for my blood pressure, and I'm partially treating a renal crisis, I don't get that spike in blood pressure, it may go unnoticed, and then you don't get on the full dose of the ACE inhibitor that you need and get the medical attention you need. And so for scleroderma renal crisis, the best prevention is looking at your blood pressure over time and knowing where it runs, and only using that ACE inhibitor if you are been diagnosed with renal crisis. So prevention is the key to modifying this medical emergency. And so we've talked about a home blood pressure cuff. The Canadians have done a lovely job. Where's Gareth? They have done a wonderful job at creating a online site for how to buy blood pressure logs, how to make sure that they're functioning properly. But the bottom line is we don't like wrist cuffs. We like regular blood pressure cuffs that give you an average of your pressure, and you should always bring that blood pressure log to your physician's visit, particularly if you have a nephrologist, and make sure your home cuff is reading against the cuff that they're using at the office. Your blood pressure should only be taken at rest. And so this is another thing patients have reported back to me. I have some patients who say, it makes me terribly anxious to check my blood pressure. I hate it because I'm so nervous I'm gonna find something that's wrong with me. And so we've talked about, the right way to check your blood pressure. You need to sit relaxed, feet flat, bladder empty, low stress environment, cool, lights off if you're very anxious about checking it. And only after 5 minutes of that restful situation, then you check your blood pressure and get that reading. If your blood pressure is greater than 140/90, or there's been a rise in your regular range of blood pressure, a 30 over the top number, 20 over the bottom number, then what you want to do is relax, take a deep breath, and repeat it in 5 minutes. And if this change is sustained, then it's reasonable to have standing lab orders, particularly if you have any of those clinical features such as diffuse skin involvement or a tendon friction rub or inflammatory arthritis. It's reasonable to say to your doctor, I'm checking my blood pressure, my pressure comes up oftentimes. Can I have orders for a blood count, a metabolic profile, including a creatinine, and a urine analysis, so that if this happens, I can go right in and get the labs. That saves you sort of the hassle of calling the doctor and getting in, and allows us, because there's two parts of the renal crisis. There's the elevated blood pressure and then the change in the kidney function. So it allows you to have those two pieces of information, and you're empowered to prevent. The other things to realize is oftentimes if you call your provider and you say, I think I'm having a scleroderma renal crisis, they will direct you to the emergency department. And this has happened, and I'm sure I'm going to have some nodding heads in the audience. Oftentimes, if you go to the emergency department, you may know more than the doctor assessing you. And so what I oftentimes say is it's helpful for you to have the information to tell them. I have scleroderma. The concern is scleroderma renal crisis. These are the studies I need. And oftentimes, they'll say, okay, that sounds good. We'll get those done. And those include, we want to know if the heart's involved. And so an bedside echocardiogram can be done. That'll look for heart failure or fluid around the heart. Pericarditis is inflammation of the lining around the heart, and that can be seen in kidney dysfunction. So just an EKG could be done if they don't have the echocardiogram available. And then in particular, this is where I talk to spouses and caregivers. If there's a sudden confusion or altered mental status, this is a diagnosis to think about, checking the blood pressure at that point. And then an ophthalmologist can do a good look at the back of the retina and look at the vessels to see if there's signs of hypertensive crisis. And the take-home message really is if you're really worried and this is a change, make sure you bring that log to the emergency department, because all they need to do is look up renal crisis and see there's a change, and then you can get the treatment you need, and that is an ACE inhibitor. Okay. I'm sorry, the internet keeps coming up and trying to connect me. So the diagnosis is made by supportive laboratories, which we've talked about, and then that evidence of end organ damage. So that's the eye exam that we talked about. Another fairly controversial area is the role of renal biopsy. And so that's really where your kidney function is abnormal, your blood pressure is abnormal, but perhaps it's not at really high levels. And so a nephrologist, which is the kidney doctor, and a rheumatologist will discuss whether there's value in doing a renal biopsy. And that can be helpful if there's question regarding the diagnosis, because there's some classic features that we can see. In the first, let me see if the arrow is going to show up. Oh, it will. Right here, this is called a glomerulus, and so that helps filter through the urine. And what we see in the setting of a renal crisis, when there's really high blood pressure, like I talked about the heart attack of the finger, heart attack of the kidney, low blood flow state to that glomerulus, it causes damage. And that can be helpful for moving in the right direction towards a diagnosis. The other thing that's fairly fascinating is that over time we see what's called onion skinning. So there's fibrosis or layers of scarring around those vessels in the kidney. And then in more advanced cases, we see some accumulation of damage. And so that can be helpful in making the diagnosis. And the reason that diagnosis is important gets back to that ACE inhibitor. And so once you've been diagnosed with a renal crisis, you do want to stay on lifelong ACE inhibitor and have that titrated to the right dose to ensure that your blood pressure is at goal. And it's really there's opportunity for good outcome with that ACE inhibitor started early, and that's well documented. So if we catch this early and you get on the right treatment, outcomes are much, much better. Some people might say, well, actually, my renal crisis is what led to my diagnosis of scleroderma, and that's very common. And so sometimes people are hospitalized for this really high blood pressure, they get this kidney biopsy, someone says, this could be scleroderma, and then those autoantibodies are sent, and then you get to a rheumatologist. So it can be seen both ways. But again, the key is the ACE inhibitor, and please know you can add other antihypertensive agents to that ACE inhibitor, but the ACE inhibitor is the cornerstone to your treatment. So the next medical emergency we're going to cover is digital ischemia. And again, this is when you don't get blood flow to your finger and the finger doesn't has an infarction. And so shown here is what we mean when we say digital ischemia. It can be pretty tricky for patients that have a history of digital ulcerations in the sense that ulcers can occur, but the difference between the ischemia and the ulceration is in ischemia, this digit is not getting any blood flow. So it's really a sustained Raynaud's episode. And so the goal for management is to restore blood flow to that finger so that the infarction or loss of blood flow doesn't occur. We want to immediately restore the blood flow, but we also want to make sure we're not missing something. And so this is a little different than ulcers. So ulcers generally will come to your rheumatologist in the office, and we'll work with you on getting the right levels of vasodilators and some wound care. This, your rheumatologist may say, I'd rather you go immediately to the emergency room because we want to try to get imaging to make sure you're getting blood flow to the finger. Because there is a condition of vasculitis or inflammatory blood vessel disease, which can overlap with scleroderma. It's a different autoimmune disease, but can be seen. And there also can be blood clots that form, and so that would require anticoagulation. So when your rheumatologist sees this finger, they may send you right to the emergency room for this imaging, or arrange this in an immediate setting, in the outpatient setting. So how do we prevent this? My goal of the talk is not to show you sort of all the horrible things that could possibly happen in scleroderma. So what I'm really going to show you it, and then we're going to talk about really what we can do so that this never happens. One of the important things is not smoking. And so this has clearly been demonstrated. And so I always feel really bad for patients that smoke, that we have to tell them not to smoke, because it's very stressful to have a diagnosis of scleroderma, and tobacco can be soothing. But I do think this is just even thinking through this picture, this is motivation to stop tobacco use because this is a risk factor for the condition. Additionally, it's good to have a team of providers in this situation. And so this is really where we use our vascular surgeons to follow along with us, or a hand surgeon. And the reason is we don't want to whisk patients off to surgery, but we want to make sure we don't miss complications. And so this may be something where your rheumatologist and wound care doctor and vascular surgeon are seeing you every week until we get you through this. This is really one of the few instances that we do think about anticoagulation, even if you don't have a blood clotting condition. And that, the kind of take-home message for that is if you have GAVE, so you have the gastric antral vascular ectasias, you want to make sure you've told your providers that, because anything that could potentially bleed by going on anticoagulation, this is really more theoretical. So you would add anticoagulation or an aspirin at this point. But again, if you have a condition that makes you bleed, communicate it to your providers. And then if infection is present, then oftentimes we'll have you take an antibiotic. However, the key prevention, again, we were talking, so first you're going to stop smoking, but then we're really going to keep a close eye on how we get good blood flow to our hands. And these are different patients, but sort of show the natural history of first the Raynaud's happens, and then Raynaud's really may, as the disease progresses, really set up shop in one particular digit. And those digits, once they have prolonged Raynaud's episodes, can develop ulcers. However, if there's absolutely no blood flow, then we start to see that infarction or kind of dead tissue that occurs. And so this ischemia, which is low blood flow, due to that severe prolonged vasospasm, is the issue here. And so what is our goal? Our goal for prevention is shown here. We want to restore blood flow. And I like this diagram. I'm going to talk you through it because I think it's important. This is how we can think together on modalities to improve blood flow. And so a lot of the drugs we use work down here on the smooth muscle. And so we usually use drugs for pulmonary arterial hypertension for that critical digital ischemia. Because the thought is if upstream we relax all that smooth muscle in that blood vessel, we're going to give a kind of a rush of blood flow to the finger. And so most of these drugs, and it's projected small, and I should say in my disclosures, I don't have any tie with any of these pharmaceutical companies or anything like that, but I do use drug names. These ERAs, endothelial receptor antagonists, work through this molecule endothelin 1. And so ambrisentan or bosentan or macitentan, you might take these drugs for your pulmonary hypertension. Or your doctor might have said to you, because you had an ulcer in the past, said, I'm going to try to get prior auth some of these medications because I'm going to try to prevent ulcerations. The other class of drugs work through this nitric oxide pathway, and these are our phosphodiesterase inhibitors. And these ones are easier to get through insurance companies, so you may have been prescribed this when you have really bad Raynaud's, your doctor's trying to treat it. And these include tadalafil or sildenafil, and I see some shaking heads that you've had access to these drugs. The other pathway is the prostacyclin pathway, and these include selexipag and epoprostenol and iloprost. Now, that's going to be a question most people ask. They say, I've looked on the internet. Clearly, iloprost is what we need to get because that's in all the guidelines. Like, why can my doctor never get me iloprost? And the answer to that question is that it's not FDA approved in the United States for access to this drug. And furthermore, the hospitals oftentimes do not have it in their hospital pharmacies. So it's not something that you can just give and then ask forgiveness later. We just can't get access to the drug. There's a lot of studies that are ongoing to improve access to these medications for prevention. But currently in the US, we're pretty limited in getting these for the indications of fingers. But that does highlight some other kind of interesting concepts, I think. So in addition to using the smooth muscle, we can also think about how to reduce shear stress on the vessel wall. So this layer of cells called the endothelium is the capillaries. So if your doctor does capillaroscopy, they're looking for changes of this thin layer of cells. And what we are very interested in prevention, of course, is making vasodilation happen, not just at the smooth muscle or upstream vessels, but at the topical level. So warming measures make a huge difference. And so warmed glove, heated gloves, making sure that you have hand warmers in your bag at all time, those play an additional role for prevention and I think are important. And ideally, we don't get to the point where we're trying to get all the access to these really expensive drugs. We're able to get there in our preventative approach by keeping your hands warm. So again, the main goal for digital ulcer and digital ischemia prevention is ensuring good blood flow to the hands at all time. And if you have particularly severe symptoms, it can be helpful to meet with a hand surgeon for a procedure and a sympathectomy, and that is best done at specialty centers. And in Utah, we refer everyone to Howard Chang at Stanford with some good results for restoring blood flow. So again, prevention being the key. Let's move on to severe unremitting abdominal pain. And I think for our patients, this is the hardest because abdominal pain can be chronic and they're every day. And over time, if you've gone to the emergency department a couple of times and not gotten answers, you sort of stop going to the emergency department. So I just wanted to cover the one condition we don't want to miss, and that is pseudo-obstruction. So this means and you can see it here in the x-ray, nothing is moving through, and that can lead to a bowel perforation. So if your belly's getting distended, bless you, and it's distended and it's painful and you're not passing bowel movements, it's reasonable to request, if you're in the outpatient setting, an abdominal radiograph. If you're inpatient for, let's say, an elective procedure or something else that you were having done, even, I would say, minor procedures, and you were given anesthesia, sometimes that slows down the gut. And so if you're inpatient, getting an abdominal CT without contrast can help make the diagnosis. The reason this is so important is because it's associated with a 16% mortality. So it's something that if you're suddenly distended and you have pain and you can't pass your bowel movement, we want to make sure that even if you have chronic abdominal pain, that those symptoms sort of trigger your request for abdominal imaging. Now, most of the time, however, it's not going to be that obstruction, but it's probably related to slow gastric emptying. And this is really hard, I think, for scleroderma patients because your doctor might have said to you, well, you have scleroderma, so your motility is really slow. But I do think it's very helpful for patients to be empowered to say, well, how do you know? What tests have you done? What supports that diagnosis? And gastric emptying studies do take time. I put the time and costs there, and these are just estimates. So it's not a completely easy study to get or to go through, but it can help diagnose that intestinal dysmotility. And the reason that is so important is because if you're diagnosed with gastroparesis or slow stomach emptying, there are some strategies or prevention so that you never get to that severe nausea, vomiting, and abdominal distension part of slow gastric emptying. And oftentimes your doctor, usually it's recommended to obtain this prior to the initiation of medications. Because that cost and that time is so much of a burden on patients, oftentimes doctors just say, well, just take the medication and see how you do. So again, if you're getting lots of severe nausea, vomiting, abdominal distension, it really is worth making the diagnosis. This is small, but again, I apologize. It's on your handout for a reason so that you have this. I apologize for people who've heard my GI talk in the past. It's borrowed from that because I think it's a real pearl for scleroderma patients to realize. And the reason is if you have gastroparesis, all those helpful things that family members have told you, you need to take with a grain of salt. And so the first is they say, well, you know what, you're losing weight. We need to get your weight up. So you should eat a lot of really healthy food. And you're constipated. So let's make those healthy foods high in fiber. If you have gastroparesis, the more fiber you add to your diet, the more distended and nauseated you may feel. And so again, that value of knowing you have the test, so you have the diagnosis, so you can make modifications to your treatment plan. The other thing is, family members love you. They say, you've lost so much weight. I made you really cheesy or buttery or really high calorie foods because I want to put that weight back on you. And if you have gastroparesis, that severe nausea, belly distension can occur. So just knowing those two facts can help you in a prevention. One of the keys, too, I think is good for all scleroderma patients is make sure you have an active list of your medications with you at every appointment. And if you can meet with a pharmacist either in the clinical setting or at a grocery store and say, I want to review with you every single one of my medications, what potential adverse effects there are. A lot of them are relatively contraindicated if you have gastroparesis. So it's just a helpful thing to know what medications you're taking if you have this condition, and can it make it worse. There are treatment options, and so we talked a little bit about your doctor might empirically treat that. The medications generally that will be used try to increase the motility of the gut. But here in the US, again, we're limited, and these medications are not FDA approved because of potential toxicities, and those toxicities that move the gut along also moved the heart along in a way that caused arrhythmia or abnormal heart rhythm. And so oftentimes before starting a medication for promotility, your doctor will oftentimes ask you to get an EKG. That's why. Alternatively, if you're really talking to your doctor, I really want to be on one of these medications, you should know that, and you can request an EKG to make sure that you would be able to tolerate the medication. Also, don't forget, treatment of nausea is important, so that not just moving things along, but treating the nausea that goes with gastroparesis. And then some of the things that doctors think to do for guts that don't work well, like Botox injections in the gut, are not recommended in scleroderma. So again, thinking through gastroparesis so that we don't get to the point where you're having to go to the emergency room for that image of your stomach. Alrighty. Sorry, it's trying to connect to the internet again. Okay. So the other thing, in addition to gastroparesis, which is common to cause that acute distension and pain, is associated with diarrhea. So this is the fact that diarrhea is present. We're less worried about that pseudo-obstruction. But sometimes as patients will say, I've had so much diarrhea, I feel like there's nothing else that I can get out of my system. The way you diagnose the small bacterial intestinal overgrowth is a breath test. And so in this, you take a test sugar, the bad bacteria in your gut ferment it, it comes into your bloodstream, and then you blow it out. And so they can quantify whether they think you have an abnormal amount of bacteria in your gut. And the bad bacteria really overgrows, like the definition, and that can cause the distension. It can cause you not to absorb nutrients, and it can make you feel pretty sick. The therapeutics to kind of prevent that acute abdominal pain and distension include those promotility drugs, cycling antibiotics followed by a probiotic, and then a close attention to nutrition. So now let's cover infection on immunosuppression. I think I'm okay on time. This is really key for anyone taking a medication that suppresses the immune system. There's 4 general indications in scleroderma where your doctor may want to suppress your immune system. The first would be the rapidly changing skin score. So your skin is getting hard and it's changing. Your doctor may prescribe you an immunosuppressant. The other is inflammatory arthritis or inflammatory myositis, which is muscle involvement. And then the fourth is interstitial lung disease. And in those instances, the immunosuppression is given to calm down the immune system so that you're not having active change, fibrosis, and inflammation in those organs. These are common ones that are prescribed. I wrote the trade names as well because sometimes people aren't quite sure what they're taking. These medications are generally increase your susceptibility to infections. All of them do, but there's also some other points I want to make since we're talking about an emergency in scleroderma. If you are on cyclophosphamide or Cytoxan, then you have blood in your urine. That is something that your doctor would want you to stop the medication and talk to them. In methotrexate, if your liver injury markers go up, then we would worry about you not tolerating the medication. Also of importance, if you're being prescribed the methotrexate for your muscles or your joints or your skin and you're getting short of breath, methotrexate can have a lung reaction, so you'd want to stop the medication and let your doctor know. If your doctor thinks you've had a methotrexate lung reaction, you can never, ever see that medication again. So that's important. That's one of those things you want to make sure you write on your medical list. Cellcept or mycophenolate is increased risk for infections, and we've already covered that prednisone is risk for that renal crisis, but also remember it affects your bone health as well. So you want to make sure that your DEXA scan or bone density is up to date on that. Those are the medication that have had a lot of research and are easy for you to get through the insurance companies. You don't see up there other medications that are used more off-label, but rituximab or abatacept or tocilizumab, those medications also fall under the immunosuppression medication list as well and have increased risk of infection.
Question?
Please.
IVIG.
Good question. So IVIG doesn't suppress your immune system. That's the intravenous immunoglobulins. So that's one doctors feel a little bit more comfortable using in the setting of they're not quite sure if there is an infection present. You can have a lung reaction to it, so it is something that any medication prescribed for your scleroderma warrants monitoring, but that's one that does not increase your susceptibility to infection.
You're talking to me about maybe getting on IVIG versus Cellcept.
And so that's exactly the reason, particularly in people who have had recurrent infections, it's one that your doctor feels a little bit more comfortable in using. The data is still under investigation. So that's the real key. And the other thing prior to getting the IVIG, oftentimes your physician will check your immunoglobulin levels. So it could be one of yours is really low, and so they're using it for that indication. It's giving the immunoglobulins to help you fight off infection so that they can use another drug. No, good question. So we've covered reviewing your medication list with a pharmacist, but it's also important if you are on a drug that's an immunosuppressant that you're keeping track how often your laboratory tests are being tracked. And so I put a website at the bottom. It's in the handout. I think is a phenomenal site, also out of Canada. It's roominfo.com. And these handouts are lovely. They're patient-centered, so you could go to your drug and print it out, and then you sort of know what side effects we're looking for. It also gives you information on calling your doctor if you have a fever or you think you have an infection. That's the key. If you are taking one of these medications, your doctor would want you to hold that till we figured out that question of whether you have a serious infection. So it's not one of those things like you keep taking until you get a call back from the doctor's office. You stop it immediately, and then you let your doctor know that you're holding it, particularly if you've been prescribed antibiotics. It is important to talk to your doctor before surgeries if you're on any of these medications. They may ask you to hold those as well. I do want to touch a little bit on wounds, because this was one of our medical emergencies that came up on that first sheet of things we need to seek emergent care for. Oftentimes patients, especially newly diagnosed, will say, I don't know if I've ever had a wound. And I think that's a real thing. We kind of throw these terms out. Oh, if you have scleroderma, you can get wounds. So I'm going to start really basic for patients that maybe are new to the conference. So wounds occur in areas where you don't get good blood flow. And so they tend to occur on the fingers, the elbows. They can occur in the lower extremities. And of interest, ones that occur on the lower extremities oftentimes are seen in patients that have a predisposition to forming blood clots. And so oftentimes if you're getting a lot of these lower extremity wounds, it's worth talking to your doctor if you've been screened for blood clotting condition. It is important to realize when they occur on your hands, they can be 3 different etiologies, and the management's a little bit different in each of them. So the first is that traumatic wound. So these are the ones, and everybody knows, you hit your knuckle, and you just know it opens up, and it's going to take forever to heal. And so that's because it has a low blood supply to that particular area. And so for the prevention part of this, patients that have contractures, it's really important that you've met with an occupational therapist and you have a strategy for prevention. And in the occupational therapist, Janet Poole's speaking at this conference, highly recommend going to her lecture. She's phenomenal. The manuals our occupational therapists have on all the assist devices and things that can do to protect your hands, your doctor doesn't know about. And so if you've never seen an occupational therapist, it's worth asking for a referral. Just at least go through the manual to see if there's anything that can be offered to help prevent those traumatic ulcers. The one next to it, I'm sorry I didn't project very well, but it's a calcinosis ulcer. These are the ones that look like toothpaste or a thin white, some people say it was like a pebble that came out from underneath the skin. These oftentimes, and I have learned this since being in practice, are best co-managed with either a dermatologist or a plastic surgeon or a hand surgeon, because your body thinks it's like shrapnel, so it's constantly trying to get rid of it, and that is so painful. And so just helping the patient out to get it managed well and cut out when it's close to the surface of the skin can be helpful, and I'll show a picture of that. And then the last is the vascular ulcers, and these occur with the really pronounced Raynaud's effect, and we've talked a little bit about prevention of those, so I won't say much more on that. I'm sorry, it keeps connecting me to the internet. All right. So the prevalence of ulcers really varies in these different cohorts, so that's why we can't tell you as doctors the best way to manage it with a lot of reliability. And the reason is this. A lot of patients get little ulcers, so if they happen to be at the doctor's office and we see that, we'll say, oh, you have an ulcer. But patients might say, well, I have it, it's just like, I just manage it at home, I don't need to do anything. And so the real question, are we only really capturing the ulcers that are really open and requiring us to use wound care? That's my message to say, if you're getting these ulcers, even if they're not present at the doctor's visit, make sure you talk about it, because they may have some strategies or medications to prescribe to improve the blood flow. But for most time, this time wound care protocol that we use in clinic, you can use at home as well. That means getting used to looking at the tissue, assessing if there's infection, seeing if there's enough moisture, and looking at the edge of healing. And I'm going to show you some pictures of that. Oops. So the first is sometimes those wounds that occur under the nail fold require nail removal in order to heal. And so this is real different in the rheumatology world. When I started our center in 2005, I was taught, leave this well enough alone. You don't want to touch this. The nail is protecting that wound. Let it heal on its own. And oftentimes, the wound care specialist will remove it to allow it to heal. And so don't take no for an answer. If someone says, oh, that looks bad, I don't want to do anything, but it's really bothering you, going to see someone with wound expertise that can remove that and help manage that can be highly valuable. They can get it irrigated, they can remove the dead tissue, and they can also see if there's a foreign body. You could have a splinter or something else that occurred. The next is seeing if infection is present. And this can be really tricky because both of these wounds were infected. The top one looks more obvious. And so anytime you are worried about an infection, taking a picture of that and sending that picture to your doctor is helpful. So I can help advise my patients. We do a lot of send us a picture of your wound and we'll try to see if we can get it healed remotely. And then oftentimes your dressing may be wet and they'll put it on and it dries and it removes the debris. Other times they'll use dry dressings. This really is up to the individual patient. Some of you might say, my fingers are so sensitive, I can't stand anything touching it, but the wet is somewhat soothing. So having an open dialogue with your physician on management is important. And then we do a lot of trying to understand the healing. And so I always say, we spend all this time ultrasound and measurements and all these things where when it's healed, So our goal, of course, is just to get it healed. And if you're able to measure it at home, then please get that measurements to your doctor. Otherwise, a wound care center can do that really well and tell if it's getting worse. For debridement, I recommend not doing this at home. So a lot of patients, and there are chuckles because patients do it at home all the time, and they tell me this, and I'm like, oh, I don't know about that. So this can include surgery, this can be the mechanical, you can do the gauze at home, but anything where you're pressurizing, and some of these more fancy ultrasonic devices are available at wound care centers. And I really point this out because this has really changed over the last few years. I didn't know, just like the occupational therapist has all those tools that can be helpful, the wound care centers have lots of tools that can be helpful in trying to get your wound healed and cleaned. And so it's worth knowing about those referrals. For debridement, this is where the calcinosis management comes into play. If your doctor's gotten hand x-rays looking for erosions, and they say, oh, the good news is you don't have erosive inflammatory arthritis, but we see all these little calcium deposits. Those calcium deposits, again, change in thinking. Years ago, we used to leave these well enough alone. So your doctor said, well, we're not going to touch them because, you know, you may not heal. But now with a lot more wound care and plastic surgery, dermatologists, they can be removed if they get to the surface of the skin, and it prevents them getting secondarily infected. This is actually one being done just in the wound care clinic next door to me, and just by soaking the fingers, putting some lidocaine, a little bit of calcinosis was stretched out. And this nice gentleman, he comes weekly to have this done and hasn't had to been hospitalized for this in years. Prior to that, when we just kind of left him alone, there was constant concerns for infection. So this is something I think that's really a preventative approach. Lastly, as we leave wounds, we'll talk about how to get to the right mix for you for your wound care. And the reason this is such a busy slide is it's not really straightforward. And so oftentimes you can have a lot of skin allergies. And so I always tell patients, be really astute when someone's putting something on your wound. Write it down. So we have patients that can do really well with medicinal grade honey. They say, that works phenomenally for my wounds. I have other patients that say, that made my finger feel like it was going to fall off. So you just have to really know what they're using on your wounds. Here are some common ones, how they're dressing it, how they're cleaning it. And then when something works, write it down, and that's your go-to. And again, it's not the same for every patient. The other thing to realize is sometimes something's working great, and then all of a sudden it didn't. Think, did we move to that spectrum of wound? Are we no longer just kind of colonized, you know, it's open, there's some bacteria, are we now infected? And so your doctor may want to add antibiotics. And in general, if you've had topical antibiotics for over 30 days and it's looking red and there's drainage, the doctor may want to give you an oral antibiotic, and particularly if there's a lot of material in the wound. Okay. Wound dressings is something that we've spent quite a bit of effort in trying to perfect. And one of the challenges, of course, is the location of the wound. And so what I always say, before you get a really expensive wound dressing, talk through with your doctor what your employment is. Are you a new mom changing diapers? Is it feasible? Because what I hate is that you leave the wound care clinic, you have this really fancy dressing on, and then you have to take it off. And so that is something that is an important conversation at the wound care center. Again, these wounds need to be watched carefully. Usually in our center, we'll see everybody every week to every 3 weeks, depending on the healing rate. But if you're doing this at home, send those pictures. That's what we really apply. We have patients who drive really far. We say, take a picture, let us know how it's doing. If we can advise you over the phone, great. If we can't, we're going to bring you in and see what's going on. I think that's an important prevention strategy so we don't get to that infected wound. So we're just going to finish up, and then the last good bit here on the change in respiratory status or chest pain. Just remember, this is something you don't wait on the phone waiting for your doctor to call you back. If you have a sudden change of breathing or a new oxygen requirement or a change in your oxygen requirement, you need to be promptly evaluated, and so that's in an emergency setting. You should know whether you've been diagnosed with interstitial lung disease, whether you have a heart arrhythmia or abnormal rhythm, or pulmonary hypertension. And to that point, I really think it's a great idea for every scleroderma patient to keep a binder. And in that is your last pulmonary function test, your last chest imaging, your last echocardiogram, EKG, and stress test, particularly if you're using any oxygen at all, because what you don't want is to go to the emergency department and they repeat everything, and your expense is really quite large, when really your question was a sudden change and shortness of breath. So I do think that's pretty empowering to have all those records with you when you go seek a medical attention. So what should your shortness of breath evaluation generally be? If you go to the emergency department, the first thing they're going to think with chest pain or pressure is, are you having a heart attack or myocardial infarction? They'll get labs in the EKG. Remember, you want records of everything so that when you leave, your doctor can have those records. What about infection, particularly if you're on immunosuppression? Have you developed a pneumonia? They'll generally get a chest x-ray, and if infection is suspected, the way they'll generally diagnose that is not in the emergency room setting, but they may admit you to the hospital and perform a bronchoscopy to look for infection. Alternatively, they may give you an antibiotic and have you take that antibiotic and do follow-up chest x-ray. Blood clots can be a concern, particularly shortness of breath and chest pain. Laboratories can be helpful. They'll do 2 different imaging modalities to look for this. One is a CT angiogram, where they're looking to see if you're not getting blood flow to a part of your lung. The other is called a VQ scan, which is a ventilation perfusion scan, and it looks to see if you're getting blood flow to the areas of your lung. In the scleroderma specific standpoint, if you come in and you say, there's a change in my shortness of breath, and you have your previous echocardiogram, you could show them the echocardiogram, and a repeat echocardiogram can be helpful for looking for a contrast to the previous result. Oftentimes, 6-minute walk tests can be done, and that sees if you have an oxygen requirement when you're exerting yourself. A high-resolution CT of the chest looks for interstitial lung disease, and then the pulmonary function test generally is not done in the emergency department, but is something that can be helpful for working up shortness of breath. Again, because we may have our first-time attendees, I'm just going to go very briefly over what pulmonary function tests are. In a pulmonary function test, you go into a booth, they put a clip over your nose, and they have you take a deep breath and exhale. And by doing this test, they can see how fast you're able to exhale at 1 second and how fast you get all the air out of your lung. And by doing this test over time, we can look for restriction of that air movement. And that restriction of air movement goes with interstitial lung disease. And so not only is it a screening test, so you may have had a pulmonary function test at baseline when you were diagnosed, and your doctor repeats this every 6 months, every year, to see how your lungs are doing. But it also can see if there's a severity or a change in severity of interstitial lung disease, and can tell you if we're giving you a treatment, whether it's working. The other thing is it can be helpful for excluding other disease processes. So again, change in shortness of breath, knowing where your pulmonary function tests run, what your normal is, and whether there's a change is very helpful. There's one particular number in that spirometry with diffusion capacity that can be helpful, and that is this reduction in diffusion capacity, and that can be seen in early interstitial lung disease. So let's say you get your short of breath, you say to your doctor, I feel like I can't do my same amount of exercise. That's a common history. So my husband and I walk the golf course, and I've done this for years, and I just can't do it like I used to. And so your doctor may say, well, we'll start with pulmonary function tests, completely appropriate. The spirometry looks normal, and they say, fantastic, there's no restriction suggesting interstitial lung disease. But if that diffusion capacity is reduced, it could be early interstitial lung disease. And so your response to your doctor is, I would like a high-resolution CT of the chest just to make sure I don't have interstitial lung disease. That should be done with prone views just to get a good look. Or maybe I have had a blood clot to my lung, because that can drop the diffusion capacity. And we've talked, there's 2 studies that can be considered, the CT angiogram or the ventilation perfusion image. Or I may have pulmonary hypertension. I might have developed that. And pulmonary hypertension, of course, is something that we really want to pay attention to in systemic sclerosis. It's part of the disease in many of our patients. And it can be due to many different parts of scleroderma. So it could be due to vascular change in the pulmonary artery. It could be due to interstitial lung disease, which then increases the pressures in the lungs. It can be due to heart involvement that causes chronic left heart disease and causes high blood pressure. And then it can be caused by something called pulmonary veno-occlusive disease, where you're unable to exchange the oxygen at the interface. And so the take-home message is really echo screens for pulmonary hypertension. Your doctor probably orders this once a year. If he or she doesn't, then what we will generally do is recommend those pulmonary function tests, that diffusion capacity. You're looking at that number and making sure that is being followed carefully, and then the right heart cath is as necessary for diagnosis. And this is what the right heart cath shows. I'm not going to go over this in detail because everybody's the last lecture, but basically we're looking at the different pressures in the heart. And again, echo can't diagnose pulmonary hypertension. It screens for it. So if your echo is positive, you don't stop there. You then get the right heart cath. And shown in your handout here is not anything more but to summarize. So you're getting your screening echocardiogram, you're short of breath, you have that in your binder. You know what your tricuspid valve looks like because these measurements exist. You then, if your doctor suspects pulmonary hypertension, they did the right heart cath. And if there's suggestion of left heart disease, they also did a left heart cath to make that diagnosis. So in summary, I hope you all learned that you should check your blood pressure and you should have an action plan if that's significantly elevated. That might include just asking your doctor for standing orders so that you can go into the hospital and get your laboratories drawn. If you're on an immunosuppressant medication, you know the name of it, and you're sure you know what regular screening laboratories you need, what vaccinations you should be on, that's the talk tomorrow, and when to hold your medications. You want to keep all your pulmonary and cardiac screening results. So anything that you've had done, make sure it's in your own folder, and that if you have sudden shortness of breath, you promptly get it assessed if it's a change. And that severe gastrointestinal symptoms and digital ischemia need to be assessed promptly, but most importantly, I think as we covered, we need a management plan for prevention. So these are things that you should actively be trying to prevent. And I'd like to take any questions. So the question was, how can you tell the difference between obstruction or gastroparesis? And that's the imaging. And so that's where the abdominal X-ray or a CT can be diagnostic in that standpoint. The helpful thing, of course, is tracking your bowel movements too, and that's hard. So if you've not had a bowel movement for several days and your belly's getting distended, that would be more concerning than if you're passing your bowel movements and your bowels abstended.
With methotrexate on a lung reaction,
Yes.
do those symptoms come on slowly, or are they acute? And
So great question. The reason it can be tricky is both. So usually with the acute onset is what is referred to the emergency department. It'll have sort of a classic appearance on the CT. The medication will be held. They can do a bronchoscopy, and there's certain cell lines that can be elevated that can kind of go with the diagnosis. They stop the medication, and it goes away. And then you say, I think this was methotrexate toxicity. In the slower cases, and that's really where your doctor said, well, this doesn't look like the classic interstitial lung disease, which is that nonspecific interstitial pneumonitis pattern or the usual interstitial pneumonitis pattern, or a lymphocytic, which we can see in Sjogren's. The pattern looks different on CT. You're on methotrexate. I'm not quite sure. We're going to stop it. Those are the trickier ones, because if you've stopped it and it goes away, you really shouldn't get methotrexate ever again. But was it truly that degree of reaction is hard to know. One of the things I will say that commonly is missed is actually aspiration. So methotrexate lung injury can look like aspiration. So one of the things you can do is you can get an esophagram with a speech therapist and just make sure you're not aspirating, because that pattern can look a little bit like that toxicity. And so I think that's something to file away. But it's one of the harder diagnoses to make, and it is really tricky, because then you can never see the medication again, and you may have an indication for it that you need it for muscle inflammation or such. Please.
Renal cysts, does that have anything to do with scleroderma?
So fantastic question. The question was, renal cysts, does that have anything to do with scleroderma? So the technical answer for that is no, and I'm going to explain that. So when we think of scleroderma is a progressive vasculopathy, and so the blood vessels in scleroderma don't work so well. And when they don't work well, the surrounding tissues around the blood vessels can respond by laying down scar tissue or laying down calcium deposits to try to reinforce or make that blood vessel work better. And then the immune system doesn't like the calcium there, doesn't like the scar tissue there, or may even incite the whole process and becomes dysregulated. So in scleroderma, there's vasculopathy, fibrosis, and immune dysregulation. A cyst is a benign structure. So in the kidney, or the liver, or really in any organ. A cyst is a benign, meaning it's not going to turn into cancer, structural change where there's the absence of tissue. And so the pathophysiology of scleroderma wouldn't necessarily include cysts as part of that. However, you argued back to me, well, if there's a lot of tissue remodeling, could you potentially get kind of structure aberrations and cyst formation? Technically, you could, so that's why I hedge everything and say, well, maybe. But in the true definition of scleroderma, or looking at case reports or large cohorts, we wouldn't see those cysts as being a large part of it. You're welcome. More questions, please? Thank you.
So you mentioned the ACE inhibitor is the choice for preventing the renal crisis. But for essential hypertension, if I heard you right, you indicated that an ACE inhibitor might limit the ability to diagnose that renal crisis when it happens. So if you have essential hypertension with scleroderma, is that still the method of the treatment?
No, so great question. So we don't like ACE inhibitors. In that case, you may be on a cousin of the ACE inhibitor called an ARB, so losartan, those ARB treatments. Those have effect on Raynaud's, which is good. It has some theoretical antifibrotic effects and are a great blood pressure medication for essential hypertension without masking that renal crisis. And it's really, and I tell you, it's very controversial, and it's been kind of, people like to study it for that exact reason. Like, well, if we're not quite sure, and my doctor wants to put me on an ACE inhibitor, will that do harm? And so I really see the bottom line is knowing how to track your blood pressure and knowing where your kidney function is the take-home message, whether you're on the ACE inhibitor or not. But great question. I'm glad you asked for clarification. Thank you so much, everyone. I appreciate it.